Welcome everyone today. We've got Dr. Tatiana Haverluk here again to talk about point of care ultrasound. And today we're talking about how ocular POCUS can detect elevated ICP in headache patients.
I am happy to be back again, talking to you about how ocular point of care ultrasound can really make a difference when evaluating patients with headaches in outpatient setting. So there's really good evidence showing that increased optic nerve sheath diameter on ultrasound actually correlates with increased intracranial pressure. So for example, if you have a patient with a headache where you are concerned for benign intracranial hypertension or other idiopathic intracranial hypertension, ultrasound can really help and actually replace a fundoscopic exam in a way that oftentimes is very challenging to perform in outpatient setting when the eye is not dilated and you're trying to look in the back of the eye. And at me as a physician myself, a provider, a lot of times I'm like, oh, I think I see the optic nerve sheath and maybe not the whole thing. And, there's a lot of guesswork that goes on. And with ultrasound, it's actually pretty clear whether the optic nerve sheath is dilated or not.
Oh gosh. So you had a case, I think, where this was indicated. So how does optic nerve sheath diameter, I guess ONSD, correlate with intracranial pressure? So what are some of the findings, and talk about just the case that we have discussed or we had published? Um,
Yeah, so we published a case a little while ago, and it was a 42-year-old woman who's been having intermittent headaches for a couple of months. She's been already evaluated in the emergency department and had a CAT scan in the last couple of months. She's also been having intermittent blurry vision, and when she arrived to see her primary care doctor, she had just this ongoing headache with not real any neurological findings. So the doctor, given her age, and she was also a little bit on the heavier side, her BMI was, I believe, 32 or something around that. There was a concern for idiopathic intracranial hypertension. So the doctor attempted to do a fundoscopic exam and they were not able to visualize the back of the eye. So they performed POCUS, and on the POCUS, they found that her optic nerve sheath diameter was 6 millimeters, which is quite enlarged. The normal is considered under 5 millimeters. So that correlates with intracranial pressure being above 20, which is abnormal, and that has almost more than 90% sensitivity or correlation with intracranial pressure. So basically, in this case, this even heightened more of a concern that this person does have um, idiopathic intracranial hypertension and should see a neurologist and an ophthalmologist and get a workup for this a lot sooner than you thought. This is not someone that you're going to keep um, telling them to follow up in a couple of weeks with a neurologist. This is someone who should have a confirmatory ophthalmologic exam to see whether there's a papilledema, and then see a neurologist for probably a lumbar puncture to see whether there's actually elevated pressure, and that can relieve the symptoms, and the person can be started on treatment as well for IIH.
yeah, and see, that's how what primary care should be, in my opinion, is you want to get that referral because those could lead to some very serious issues. How can POCUS findings influence decision making in patients with recurrent or atypical headaches?
Well, I think that's it. It's really evaluating that optic nerve sheath diameter to see whether there's indication intracranial, increased intracranial pressure. So it's replacing that fundoscopic exam part that's I've mentioned is difficult to perform, and you can expedite. Yeah, like this patient needs a lumbar puncture, and it should be performed in the next couple of days rather than in 3 weeks. So you're just expediting all of their workup, and hopefully also avoiding unnecessary repeat CAT scans. Like in this person, maybe she needs a more precise imaging rather than a non-contrast CAT scan that she just had a few months ago.
if someone was presenting with headaches in general, that would be, when would you go to this?
More if I'm actually concerned for IIH. So
Oh,
if someone is maybe having intermittent blurry vision, is having persistent headaches for a long time, but no real diagnosis, I wouldn't necessarily perform it on all the patients who have been
right.
diagnosed with migraines, for example, and are on treatment for migraines. Um, so it really depends a little bit. And I was going to also mention that another part that's important about doing POCUS in these kind of patients is that it's also the reassurance element for the provider and for the patient. So say you do it and you don't see increased optic nerve sheath diameter, there's a certain kind of, relief that that's not the case, and you have a little bit more time to work that patient up.
So, describe an ocular ultrasound. What is that? How does that work?
Yeah, that's a fun one, especially when you do a workshop for people who haven't really experienced too much
Even heard of it.
ultrasound in the past.
Yeah, I've
Um,
never even heard of it because I've been a part of, I've attended hands-on, but I've never seen an ocular.
yeah, no, it's a crowd pleaser. So, but basically, we put a sticky film, kind of like a tegaderm, on the eye. We have the patient close their eye, lie down usually, and then we put a ton of gel into the orbit because you don't really want to be touching the eyeball or pressing on it. So you're scanning through the eye. And you're looking at the eye in a transverse orientation and a longitudinal orientation. And you're evaluating kind of the anterior chamber. You can look at the actual lens to make sure that it's in a good position and not dislocated. You're looking at the posterior chamber, which should appear black. And if you're seeing kind of more hyperechoic or some debris in it, that could be concerning, for example, for a vitreous hemorrhage, which could also, if patient presented with a blurry vision and you're finding that vitreous hemorrhage or signs of it on ultrasound, that would be concerning and would need an expedited workup. Yeah, and then you can actually see the retina. And one of the things we do in the ER a lot of times, we'll look for retinal detachment or vitreous chamber, posterior vitreous detachment in patients with blurry vision, floaters, or the ones that present with kind of like their vision going out and it felt like a curtain was coming down. So those are like classic presentations. And for optic nerve sheath, we measure 3 millimeters behind the retina. There is a tubular structure that appears a little bit black or hypoechoic, anechoic. We measure it across, just pretty simple. And the cutoff is 5 millimeters. And if it's more than 5 millimeters, it's concerning for increased diameter, and you need to kind of correlate with symptoms. Look at the other side as well to see whether it correlates. And go from there.
Interesting. So, touch on the billing and coding part of that particular.
Yeah, I mean, ocular ultrasound comes with its own CPT code, like most of the POCUS exams. So it's more, it- you know, uh, documenting it appropriately in the chart and also putting in your medical decision making. Why was POCUS performed? What it added to your workup? And say, you attempted fundoscopic exam, you couldn't visualize optic nerve sheath. Hey, I used point of care ultrasound to see whether there's any signs of optic nerve sheath dilation instead. So there's a great education. And then you need to put the procedure note. So in the procedure note, once again, it's indication, your findings, what views you obtained, and then the final impression.
That's really cool. Very interesting case. Thank you.
Yeah, of course. And I was going to also mention, ocular ultrasound. So this case is specific for a patient with a headache, but you can use it for patients with visual changes. So I mentioned already vitreous hemorrhage or retinal detachment. If someone has double vision and maybe they had trauma recently, you can look for lens dislocation. You can look for foreign bodies. So a lot of other applications as well. And in my experience, getting an ophthalmology consult emergently or urgently is actually quite difficult, even in a city. I live in New York City, and sometimes it's not that easy to have an ophthalmologist come in and see a patient.
The
So this is
sooner
just
the
an
better.
extra tool.
Yeah, the sooner the better too. So thank you for this case and the information. This was fantastic. Thank you.
You're welcome.
Please support our mission to improve quality of patient care through education. Join us, follow us, and share this content with family and friends.